Hi, this is a recorded lecture for HSC 400, Healthcare Analytics. And in this particular lecture, we're going to look at Chapter 6, which is Working with Data. And it's really important to understand that, that we really need to focus our decisions in healthcare based on data, evidence-based data. And you're going to hear that a lot, especially in nursing and in medical school, is that you're going to hear that a lot of people talk about that. And evidence-based approach to care is really important instead of just saying, well, I like it this way, versus what is best for the patient or what has best outcome. So data is clearly an essential component of analytics, and healthcare data is usually much more complex. In a manufacturing world, they may make a hammer one way. In the world of healthcare, we may do a procedure 10 different ways based on some very specific characteristics of the patient and their disease. Now, there are many dashboards and reports in healthcare today, and they're usually pretty simplistic. They're often incorrect in many areas, and so they've become antiquated. They've gotten older, and they've sort of degraded over time. Now, data is the raw material of analytics. I think we said that and established that. It's the raw material for information. And data is continually generated by healthcare professionals and the organization. And analysts use the data and enter refined data back into the system often. And the understanding that data is the foundation for all analysis is important. And this is really an important step because it costs more money to put in good data than it does to put in bad data. Now, let me explain what I mean. If you want someone to put in just whatever they can, and they put in bad data, they can put in a lot more information, or they put in a lot more records than a person who puts in good data who's following quality control procedures. So with that, you need more man hours to put in good data than bad data. And many organizations try to cut their costs by cutting the people that do that and just increasing their productivity ratings, the requirements. Well, that's all well and good, except here's what happens. Those dollars you saved by cutting your data entry people, well, guess what? You're going to pay for that at the other end. And the reason is because the data will no longer be as robust and as valuable and as trustworthy, and the decisions you make will be not quite as well informed. And people will stop trusting that, and they'll start making decisions based on emotion or gut feeling instead of the data that you have. We look at information value chain. Obviously, you start out with data as your basic food group. You have to analyze that data and come up with some usable information. It has to create this action, and the action will create the outcome. Now, I always think there's another place way out here, and that is you have to continue to measure when you make this outcome and you make a change. You have to continue to measure way out past that. If you make a change and you don't continue to measure that change for an extended period of time, people revert back to the way it was before because it was usually easier or it's the way they knew. So to make that different, to make that more sustained, you have to continue to measure. Now, preparing data for analytics, an analyst needs to know the following: what the data represents, what processes, what workflow, what outcome, or what structural component does the data correspond to? How is the data stored? What kind of storage is the data in? How good is that quality? What is the data type? What kind of data do the values represent in real life? And I say real life, in other words, we collect data sometimes that isn't really transferable into any usable information. The analysis needs to logically, they need to know what they logically need to do with the data, given the type of data and how it's stored and how it can be analyzed. And then how could the data be used to create information? What characteristics of the data dictate what it can be used for? And we'll find that as we get through this lecture that we'll see that different data has different characteristics and different usability. For instance, if you have data that's numerical, 10, 15, 26, 1, or whatever, then that's pretty reproducible. That's pretty finite. What if we have data that's based on context, so we take information out of records based on that, and we make decisions because we've done a data mining into records to see if certain things are represented? There's variation in that, and so you have to be very careful. Understanding what data represents, successful quality improvement and process improvement in healthcare modify and improve business processes, clinical processes. They reduce waste and reduce the likelihood of medical errors. That's what this is all about. That's why quality improvement and process improvement is so important. Now, data must be analyzed with consideration as the process and the workflows that are being evaluated. So it must be analyzed within that context, within that parameter. Now, aligning processes with data, because healthcare systems are dynamic, processes are constantly changing, and that's very true. We had a process in an oncology department that changed 4 times in a year because of discoveries in certain treatments that they changed literally 4 times in 1 year. And they were improvements over the last 3. The last one was more improvement over the first 3, but it was consistent change. The data we collected was very different because the success rate became much higher because of the improvement. Data stewards are often not informed of such changes and may not keep up, so you need to keep your data stewards up to date. Analytics professionals must work closely with business subject matter experts who can relay recent process changes and validate that current assumptions are actually occurring. When you're doing analyses, you have to get with the business subject experts, the business matter experts, the clinical experts, and make sure that what you think they're doing is what they're doing. Now, what's really interesting is when you go in and do process mapping, even what they think is going on may not be going on. We looked at a revenue process in one of our departments, and the department director said, this is the way we do things. And we went back and did a mapping of every person that did that process, and they all did it differently. Some better, some worse, all different. And so in 8 people, there were 8 variations, and if you stick to the 6 Sigma concept, 8 variations gives you 10 to the 8th chance of having a mistake. And they did. They had lots of mistakes. Now, let's look at a simple ER patient arriving and assessment process. So the patient arrives, they go through triage, there's registration, they transfer to the treatment space, the nurse goes through assessment, and then there's a physician assessment. So we look at triage here. The nurse performs a preliminary triage assessment of the patient, determine his or her presenting complaint and the urgency of that, and they identify all the times the data we collect. The patient arrival, we look at that. The registration clerk does all this, and we see that down below. So we see that we start to look at those processes step by step, and we look at the time in, time out, and we start to see where our bottlenecks are. For instance, if the patient waiting in the ER is all around the triage nurse, is that what people used to say, well, the triage nurses aren't doing their job. What usually happens is the triage nurse is doing more than his or her job. And the truth is that the triage nurse is usually overwhelmed, and adding new patients to the system is only one part of that process. Patient arrival, sometimes we find we have 1 registration clerk, we need 5. And so organizations will try to save money by going to 1. Important information to consider about each data point. Who performs the activity that generates the data? Very important. Who enters the data elements in the system or causes the data to be generated? What is the trigger for the data to be stored? What type of data is stored? Numeric, alphanumeric, or date and time? And believe me, it's interesting because you'd be surprised how often you see mistakes here where the date and time is interpreted as numeric or vice versa because of the way that the field is keyed. What business and validation rules are associated with the data item, and what data is required to provide the information insight required to address the quality and performance goals of your organization. All of these are important considerations when you look at each data point. Now let's look at the types of data. Data can be divided into 2 basic types, and we're going to get a little more statistical analysis here as we look forward. We have quantitative data and qualitative data. And quantitative data, you can think of as numeric. It's obtained from observations. It's easier to summarize and analyze statistically. It's usually a quantifiable number, 20 over 100 or 10 over 50 or something. And so it tells you that we saw 50 patients yesterday because we ticked them off, 50 patients, and there they were. Qualitative is different. We treated 25 patients and we gave them quality care. Well, what does that mean? Well, it's more descriptive. Information is based on perceptions of individual or focus groups. It requires more preparation prior to analysis, but can reveal some pretty important insights into quality and performance that standard quantitative analysis cannot pick up. That group that we talked about that had 8 different variations, well, lo and behold, we found that by mapping the process each one did and found the variation. It was pretty interesting. The department manager, department director, manager, whatever it was pretty embarrassed. Now, we think about electronic data storage. Data in each field or object will be defined four major attributes. The first is the kind of data being stored, whether it's numeric, character, binary, or etc. The size or length of the data being stored, for instance, how many characters are in a field. It used to be in the old, some of the old software, you got 4 or 5 characters when maybe you need 10 or 11. And so you would start to abbreviate. Well, people would abbreviate differently. And so when you went to look for the data, you found the abbreviations were all different. And there wasn't, when you tried to analyze it, you weren't sure what you're looking at. So the simple thing was to go back into the software and increase the field to more characters. The precision of the data for numeric data only, i.e. the total number of digits in the number, does it go down to 4 decimal places, or does it go down to 1 decimal place? The scale of data for numeric data only, the total number of digits that fall on the right of the decimal point, as I said before, the precision and that scale. Now, data fields and data types, for example, the first name, for instance, you see that as Varcher 255, you have 255 ability. And the last name, 255 characters available. ID number, chart ID number, it's 8 is the standard. Date of birth is the date, and so the length is going to be, there's no decimal places or anything like that here. The height is going to be in a standardized way in centimeters. Weight's going to be in kilometers or pounds, height in inches. And the acuity score is going to be very specific. So this is a way of looking at data fields and the types of data. In this case, it's you see the different approach. This is integer, floating number, if you will, and then varchar, which is a way of looking at textual information. Now, data types. You have to ensure the integrity and management of the information being stored. Data type assigned to a database field dictates what operations can be performed in the data field. For instance, if you're looking for dates, if you will, and it's not a date field, it'll be very hard to collect the information. Now, the challenge is when data is coded inappropriately, like a temperature of 37 degrees is stored in a text type data field, and you can't be easily collected except for data mining. That's not very helpful. Levels of measurement, and this looks at the classes of data, the levels of measurement. We have categorical, ordinal, interval, and ratio. For instance, let's look at categorical. That's non-numerical data that's placed in a mutually exclusive, separate but non-ordered categories. For instance, categorical, nominal. That means let's look at the people on a football team. They all have numbers on their back. Well, they don't really categorize them in most cases in high school as anything what they do. It's like every quarterback only has the number 8. They could have any series of numbers to a certain point. Ordinal, that's the data we organize and ranked in numerical fashion and for which order matters. The difference between values is not meaningful or constant. We can say that we have 10 patients that came in with flu, 10 patients that came in with diarrhea, 10 patients came in with whatever. It doesn't mean that 10 patients with diarrhea are worse or better, that 10 is more important or that we use less time. It doesn't really tell us that. Interval, that's the data is measured on a scale where the difference between 2 values is meaningful and constant. The difference between seeing 10 patients in the emergency room and 100, that's a pretty important difference as far as the volume. Then ratio, the measure where the difference between the 2 values is meaningful and consistent, and there's a clear definition of 0. There's none of that variable, there's none of that variable that actually equals 0. So what it means is a ratio. 5 out of 10 people did this. 2 out of 10 had this. Now, categorical and ordinal data, in this illustration of categorical and ordinal data, this is an example of categorical data, the emergency department locations. Rescue, triage room 2, resuscitation, triage room. You see the numbers? These numbers don't tell you anything as far as where they're located other than that's the number assigned to them. So it's just categorical. They just put numbers on them that are arbitrary. Example of ordinal data, the triage acuity, 1 through 5. That means a person with 1 is less acute than a person with 5. But it doesn't tell you anything else. When you look at interval and ratio data, that's the interval and ratio values was the temperature example. For instance, we look at weight here. We have 0K, 275K, and 375K. We see the difference using temperature, for instance. We can see that based on looking at we can look at centigrade and Fahrenheit. We have to be able to apply those, and we can use those one to the other. Most measurements are taken in physical science, engineering, and medicine are done on a ratio scale. For example, reading the mass, pounds of kilograms, times, seconds, and hours, and blood glucose, that all start at 0, which represents an absence of a quantity. There's nothing at 0. If you have 0, you have none of the above. Now, getting started with analyzing data. Analyzing data properly to attain meaningful results. Analytics requires that we know what kind of data we're dealing with, and we've said that lots of times. Just looking at the data is not sufficient. In fact, sometimes when you look at that sort of like an eye look at what you're doing, usually you're not accurate, especially if the data is more complex. Now, if you look at data and 50 people waited an hour and one person waited 10 minutes in the emergency room, you can sort of make some decisions based on that data. But that doesn't give you all the information. Let's say those 50 people that waited an hour were 50 people that came in at 5 o'clock on Monday. And the one person that waited 10 minutes was the person that came in on Sunday afternoon. So that only tells you the over quantity. It doesn't really give you the texture of the information. The data type determines what computations can be performed on it. We've already said that. Now, when you summarize effective data, regardless of how data is used, the strength and value derived from the analytics is the compilation and analysis of large amounts of data and our resulting synthesis. In other words, regardless of how the data is used, we need to be able to analyze that and create some sort of a result. This makes it meaningful to clinicians, nurses, PAs, nurse practitioners, doctors, administrators, quality improvement and process improvement teams, and leadership. It has to create a visualization of the data for non-statisticians to see and understand. And most people, even if they've taken a statistics class somewhere, are not good statisticians because most people other than analysts really don't hold on to that information for an extended period of time. We sort of know what it's about. We've touched it once or twice, but we try to forget it because it's painful. Now we have an overview of data summaries here. We look at count, mode, percentile, median, minimum, maximum, summary, mean, variance, and standard deviation. And I want to talk about these a little bit as we go through. The count is just really a tally of the values, and it applies to these types of numbers. The mode, that's the most commonly occurring value in a data set. So a mode is the one that if you have 10 different numbers or 10 different measurements and they measure, for instance, triage of patients 1 through 5. Let's say 15 come in for 3, or are triaged 3 and the other are only one patient is triaged for the others, then your mode is going to be the one that's the 3 one with 15. Percentile, it's the value of data set below which a specified percentage or observations fall. And a percentile is the percentile. So if you're saying if you look at 20 results and you start to identify the bottom 25%, the next up 25%, the third 25%, the fourth 25%, those would give you the percentile, so to speak. So you can say for instance, you fall in the 15th percentile. That means that you are, if you are not the 100th percentile, you don't do 100% time, but you're about the 15th percentile. The median is the midway point of ranked order data sets, the value for which 50% of the data elements set, also known as the 50th percentile. The minimum is the lowest value in the data set, the maximum is the highest value in the data set, and the summary is really a description of what you can discern from this. Now the mean is really the thing we use all the time to discern whether the average of things, and it can be helpful and very deceiving at the same time. So it's the average of all the data. We add all the stuff up, we divide it by the number of entries. Now that's all great if the data is kind of coalesced together, but if there's strong outliers, those strong outliers will dictate the average, and they may happen rarely, and so we are making a decision based on the influence of these outliers, and when the real decision should be based on taking those outliers out and looking at the information inside of where it's all coalesced. Variance, that's a measure of how spread out the numbers are within the data set, and is measured by the distance from the mean. And then standard deviation, that provides a sense of how the data is distributed around the mean. It can be considered an average of data points distant to the mean. So that's the way, the standard deviation is a really important thing. Let me say this in a little different way. If you do a study, and you do a statistical analysis of something, and we're looking to see what the variation is, and we look at the ways a certain process is done, and they all fall within the first standard deviation, that means essentially they're all about the same. If they start falling away in the second, third, fourth standard deviation out, then there's more variation. But if you say, okay, we went in and did this change, and the change moved this process, 2%, and then we do a standard deviation evaluation and find out it's within the same standard deviation, you really didn't do much. It was probably more serendipity. The other thing you find that's really funny is Peter Drucker likes to say all the time that what is measured is corrected. And what he's talking about is what's called the Hawthorne effect. Let me put this a different way. If you're doing a process and nobody's watching, you'll do it a certain way. If I stand over the top of you and I track what you're doing, I measure what you're doing in some way, then you'll do it correctly more often than when somebody's not watching. So what's not measured isn't necessarily done correctly. You have to measure the stuff that's critical to an organization has to be measured in such a way that you can start to find where the cracks are in the process and correct those cracks. And that's a constantly reoccurring dynamic process. You can't fix the cracks and say, okay, I'm done for the year. They will reoccur and reoccur and reoccur based on the dynamics of healthcare delivery. Now, counting data is the simplest operation to perform, yet it is one of the most common and useful ways to look at data. It answers how much or how many, and many QI and PI projects are concerned with reducing or increasing something. If you look at variations, for instance, we had 10 variations on the theme. Well, we like to have no variations on the theme, and that's the counting process. Frequency distribution. That's defined as a count of occurrences of one or more values or ranges of values that represent a sample data. And this used often for quality improvement and process improvement, the number of a type of surgery done every week or day or year, and that gives you that frequency. Frequency distribution can display the actual number of observations of each value or the percentage of observations. For instance, we do, of 100 surgeries we did, 25% were appendectomies, or 10% were gallbladders. Cholecystectomies. So we could do it that way. So it's appropriate for all types of data values, categorical, ordinal, interval, and ratio. So frequency still applies. A good look at frequency distribution is at those triage levels. So here's the visits, and here's the number of visits that were identified within those triage levels, and it also shows percentage. So there's the N. That tells you the number of the total number. So we had all these visits. Only 364 were categorized as 1. Only 904 were categorized as 5, but most of it falls within 2 to 4, and that's actually true. That's actually where most of it's at. So you see that most of your cases in an average emergency room fall within the middle 3 areas, not so many in the first, not so many in the last. Now, if we talk about more additionally frequency distribution, data graphing capabilities help non-statisticians to understand the data better. For instance, if we put this in a pie chart or we put this in a bar chart, they might help them to see that better. Bars, graphs, pie charts, etc. are often used to help do that, as I said. This is looking at a bar chart, if you will. This is looking at that. You see, there's the triage levels, and boy, you can sure see that most of your triage is going to be triaged at 4. Now, is it really 4, or are your triage nurses making the acuity higher inappropriately? So if we look at hospitals around our area, or hospitals in the nation, or hospitals that have our characteristics, are our triages higher? Are our triage levels higher or lower or consistent with those? That's important because you're looking at evidence-based data. So if you have 5 triage nurses who are trying to make it look like they're doing more work, if you will, I'm not saying that's bad, they do that, but if let's say they are, that sounds derogatory, but I'm just using an example, then you could say, okay, well, every other hospital in our town, these are more equal, or they fall down to here, if you will, all 3 of them. Why are ours worse? What do we supply that's different? If the answer is none, then you have to go and see how we're triaging those patients and see if that's correct. We can also use a histogram, because sometimes a detailed graphic is necessary to show if the data clusters around a single point, if there are outliers, and what their overall shape of the data is. And histogram is used when the data is numerical to observe the shape of the distribution of the data and determine the extent by which the outliers exist. A good histogram is this, for instance. So we have the histogram of the length of stay in the emergency room. So we have histogram, length of stay in hours. We see that here. We see frequency. We see frequency, and this is the stay A and stay B. And so this may be the 2 comparisons, if you will. So we see that our length of stay is really most of our patients. Very few patients are out past 10 hours, as it were. In this one, we're consistent. So these are similar in how they look. For instance, the 0 they have 0 hours, and then we look at the first hour, we see that falls low, and then we see the differences here down the line. So this is a histogram, as it's called. Now, a histogram is when the shape represents a bell curve. That is, it kind of flows up and down like this, a bell curve. A statistical test can be performed in that data a little differently. If the data distribution is when the data is skewed to the right or left, and this is skewed data, this is not a bell curve. Well, it's not a very good bell curve. A bell curve would be kind of like this in the middle. So this is kind of skewed, if you will. It's more negatively skewed. Histogram is used when the data is numerical to observe the shape of the distribution data and determine the extent by which the data outliers exist. So a histogram will give you that information, and we've seen that. So when the distribution can have two peaks, it's considered bimodal. So when you have a peak here and then another peak, that's considered bimodal, and that suggests that the sample may not be homogeneous or perhaps drawn from two independent populations. And what it could say is there are two distinct groups within that data. In my doctorate, in my dissertation, I literally had several bimodal results based on influences based on two different influences within the data. So I did have two distinct populations within the overall population, and that proved to be very descriptive of what was going on. Now, central tendency is when you look at quantitative data, that is the numerical data. The values are not spread evenly across the range of possible values, but tend to cluster or group around some central value. And a measure of central tendency is an attempt to describe the data as accurately as possible using a single value that describes that, so it says it's all in one central area, so to speak. The three most common measures of central tendency is mean, median, and mode, and you'd be surprised how people mix them up. The mean is the average. That's the most commonly used method of summarizing data, but it does not take into account the outliers. There's the mean. A median is where 50% of the data points are above and 50% data points are below. Now, if all the data points are even, like there's 10 of them, then you go between two data points, of course. But it's associated with percentage or percentiles, and the median is given as the 50th percentile. It's not impacted by extreme outliers because it's just looking for the middle of the data. The mode is the value of the data that occurs most often. So if you have 10 different reporting, like the triage thing, the mode would be probably the fourth category because it was the highest. Now the big picture, consider a data set containing 3 months of visits data for a mid-sized emergency department during which there were 11,472 visits. There's the value, here's the statistic. The average was 4.86 hours waiting, but the median was 3.25, so there were some outliers. The maximum was 23.97, and so you can see that there were some really high outliers. The 25th percentile was up to 1.88 hours, the 75th percentile was up to 5.68 hours, and the 90th percentile was at 10.37 hours. So we start looking at this, we can start to see, and the reason you don't put in the average is because the average is really the 50th percentile, right? So you have 25, 50, 75, and then there's 90. Here's looking at the big picture a different way. Here's looking at that waiting, the histogram. What you're seeing is that this is looking over hours waiting in the emergency room, that most patients actually get out within the first 10 hours. You think about, look at the different percentiles here. There's 25th percentile, and we see all that, the 50th percentile, and we look at the 75th percentile we see as we go out. And so there's 75th, there's the 75th, and then we did the 25th and the 50th. So you're starting to see that even though this goes out to past 20 hours, most of the patients are going to fall underneath the 50th percentile. That's actually a good thing. And so the central tendency shows that most of the information, or most of the patients are getting out in this group. There are some that are extended. That doesn't mean there's not a problem. It just means you're looking at it differently. We use what's called a box and whisker plot, and these are kind of interesting to me. I always found these to be kind of interesting. The lower extreme, the smallest value of the variable, that's down here. The first quartile is really here, and then the median is really right here. So the median is going to be the center of the data. The third quartile is here, so we're at 75th. We're at 75th. So at the first quartile, this is 25% fall below this. At the third quartile, it's really 75% fall here, and the upper extreme is out here, and then we have outliers that fall out. So this is just a way of looking at what's called the box and whisker plot. I always found these to be less than helpful over time, but a lot of people like them for whatever reason. Now this is the box and whisker plot in the emergency room looking at lengths of stay, and we start to see level 1, 2, 3, 4, and 5 based on the triage method we did. Now isn't it interesting that in level 3 and 4, our lengths of stay are much higher than in level 1 and even in level 5, because obviously they're moving right from the emergency room to wherever they're going to be treated. They're being stabilized in the emergency room and probably going to surgery. So they move pretty fast because it's more acute. The acuity is higher. But look at here. Look at the length, or look at the length of stay as we go higher. Much higher here. The length of stay here is probably based on the people having to wait, because as acuity goes up, guess what? The patients are seen first. It's not a first come, first served process. It's a worst is first process. So worst in, worst out kind of thing. And so that you'll see that this center area probably has some outliers because they had to be kept in the emergency room and be stabilized longer, or maybe they didn't have a bed in the hospital for them, or those kind of things. If we look at scatter plots, we start to see that what's happening in the emergency room as far as we put a dot where everything fits as far as the percentage, and we start to see the left without being seen area, for instance. So this is left without being seen. They got tired of waiting. So most patients that left within the first 2 hours. They didn't get treated in the first 2 hours, and then they left. It's interesting, only a few lasted 4 hours that went out. So if you look at this, about the 10% mark here, most of our patients fall within that group. It's really interesting. Now the summary is that most analytics for quality improvement and process improvement require only descriptive analysis to effectively communicate that issue. That's true. However, often, not sometimes, but often, more complex statistics are required to present the more sophisticated data. In healthcare, it's helpful. The trouble is that the more sophisticated analysis suggests more sophisticated reporting, and when you start showing that information to non-statisticians, they get lost sometimes. So you want to be able to translate that information in a way that gives them the information in a way they can digest it. So statistical analysis should never be a substitute for good data. You can't fix bad data with good analysis. It doesn't work. And you have to have well-defined metrics. Thank you very much.